So welcome everyone to the Visiting Scholars Lecture. Today we have the pleasure of having Dr. Kim Waddell. She is an assistant professor in physical medicine and rehabilitation in the Perelman School of Medicine at University of Pennsylvania. And she's also a research health scientist at the VA Center for Health Equity Research and Promotion. She received her PhD in movement science and her master's degree in clinical investigation from Washington University. And I know of her work from then. She did some really fundamental work on looking at activity in upper extremity stroke, real world activity in patients with stroke for upper extremity. And one of my favorite papers of hers was the one where she showed that despite improvements in the clinic, those improvements don't translate at all in the real world. 0 out of those 72 participants changed their arm function, 72 or 73.
78.
There you go.
So it's incredible memory.
But somewhere in the 70s. She's also an occupational therapist who received her master's in occupational therapy from the University of Carolina at Chapel Hill. Her research focuses broadly on improving long-term health outcomes in adults with neurological disease by leveraging insights from behavioral economics. And we're going to hear her work on how to use that to improve outcomes for patients with stroke or Parkinson's disease. So welcome again.
Thank you. Thank you. Good afternoon, everyone. It's really nice to be here. I can't believe it's taken me so many years to get to come up and visit here. It's been really fun to see your space and get to see so many of you. So thanks for the opportunity to be here today. I thought I'd start with a little bit of an introduction to myself and my training. I often get the question, how does an OT with a PhD in behavioral economics or a PhD in movement science end up in behavioral economics, which is a fair inquiry. And so I thought I might start by telling you a little bit about how I got here. Maybe if the slides will advance. I'll spare you my total life story. And instead start with OT school. So I went to OT school at the University of North Carolina in Chapel Hill. And as a newly minted OT, I wanted nothing to do with research. I wanted to work clinically. And so I packed my bags and headed to Chicago, where I worked. I'm going to date myself. At that time, it was the Rehab Institute of Chicago, and now the Shirley Ryan Ability Lab. I worked there as a full-time clinician for about 4.5 years, all in inpatient rehab. And of the many things that make the Shirley Ryan or RIC special is a 1-year grant fellowship program that they offer to clinicians where you can apply to do a small research project. And so I applied and received this grant in 2012 and was actually mentored by Catherine Lang from WashU, where it tested the feasibility of task-specific training in an inpatient rehab setting for people post-stroke with upper limb paresis. And it was through this project that I started to get a little more interested in research and thought, I think I might want research to be a bigger part of my career than I originally thought. And so when an opportunity came up in Catherine's lab to be a research therapist on her dose response trial for upper limb movement, which I'm sure many of you are familiar with, I packed my bags and headed south and moved to St. Louis. And I worked as a treating therapist on that project for about 1.5 years. And then ultimately went back to do my PhD in movement science in Catherine's lab. As it came up in the introduction, really the thrust of my PhD research, and I'm going to talk a little bit about it today, was asking the question of if people get better in the clinic with rehab services, do those improvements then translate to home? And very unfortunately, the answer was no. And so I started to realize that I was thinking a lot more about, well, if people aren't translating what they're learning in the clinic and getting better with therapy in the clinic to home, what will it take to help people improve their behavior at home? How do we help people change their behaviors and translate these skills? And that's when my personal interest in behavioral economics started to intersect with my research interest. And so I pursued a postdoc, and that's what brought me here to Philadelphia in 2019, where I did my postdoc in the VA Center for Health Equity Research and Promotion, as well as the Penn Medicine Nudge Unit. And I spent 3 years just immersed in behavioral economics and trying to understand and learn as much as I could about human decision-making, how to motivate people to make decisions that were more aligned with their long-term goals, and just had a really fun experience and loved it so much that I stayed on as faculty. So I am now currently at Penn as an assistant professor, continue to have an appointment at the VA Center for Health Equity Research and Promotion, which sometimes feels like two full-time jobs. And I'm also on faculty in the nudge unit. So that's a little bit about myself. I did want to pause and just acknowledge, we have quite a bit of work going on. The center stake in all of the work that I do is behavioral economics and behavioral science. We have lots of projects going on, though, that focus on clinician behavior. So we talk about and think a lot about how to use the electronic health record to design and deliver nudges or different interventions, clinical decision support to help clinicians make the right choice, the easy choice without adding burden. And our nudge unit portfolio is really all focused on clinician behavior. I'm going to focus my talk today on the middle, patient behavior, so I'll skip over that for now. And we also have an arm of work in health services research, where I have largely on the VA side and just received a pilot on the Penn side where we use EHR data, claims data to help understand patterns of care and care processes, and how those impact access to care, quality of care, and who gets it, mostly for people post-stroke. And the goal of that work then is as we understand these patterns of care, and using administrative data, can we then design, nudges or use the electronic health record or clinical decision supports to help improve the decision-making for where someone goes for rehab or the type of rehab that they get. So I am happy to talk about any of this work today if you have questions, but I am just going to focus on the centerpiece, which is patient behavior and patient decision-making. And so our circuit today that we're going to go through is we're first going to talk about the problem that I study and trying to understand the problem and what motivates my work and what keeps me up at night. And then we'll move into a really brief discussion of behavioral economics, and then how we apply behavioral economics and scalable technologies in our work, and then end with some discussion. Please also feel free to jump in at any point throughout the talk as well. And my lung capacity is significantly decreased with being pregnant. So if I sound like I'm walking uphill, I am okay. I just have a bit reduced lung capacity. And I want to start actually with when we try to think about this problem by asking you to pause and think a little bit about time with me. So if we take someone who has had a stroke and they are getting outpatient PT, OT, and speech, and they come twice a week to see us. That's actually pretty standard in our health system, is to come 2 instead of 3 times a week. That is 6 hours of the week that they're spending with us in the clinic in outpatient therapy. That leaves 162 hours where they are at home each week or in the community or with others. Now, historically, we have spent a significant amount of time and research dollars on these 6 hours in therapy. How do we design the right intervention? What type of care should we be delivering people? And we have spent significantly less time on the 162 hours where people are not with us, where they're at home. But we know decisions made in these 162 hours are strongly associated with your outcomes and your long-term function. And so my research really focuses on the 162 hours of what someone is doing when they're not with us in the clinic, and how can we help maximize outcomes in that environment. And so I like to think about this and conceptualize this issue by thinking about capacity versus performance in rehabilitation. And the ICF actually helps us to do that. If we look at the activity domain of the ICF, there are 2 subsections of that domain: capacity and performance. So capacity is what a person is capable of doing in the clinic. And we measure capacity using standardized assessments, the Action Research Arm Test, the Wolf Motor Function Test, 10-meter walk test. And it's a direct measurement in the clinic in a standardized environment. Performance, on the other hand, the ICF describes as what a person does in their home environment. And you can imagine performance is a little harder to measure. So we tend to think about it, you can measure in 2 different ways. The first is you can measure perceived performance using a measure of self-report, like the motor activity log, or asking people how much did you walk, or using a self-reported measure. Or there's more of a direct measure of performance using sensors, accelerometers, Fitbits, and wearables. I am not here today to put one against the other or say that one method is better than the other, but I will say that in my work, I use a direct measure of performance and using wearables or sensors. So all the data that you'll see today comes from, is from a sensor, and we don't have any self-report measures. And so backing up, and this came up in the introduction, but we often assume that the improvements that a person makes in the clinic in their capacity directly translate to improved performance at home. But we had never really tested this assumption. And so the first project for my dissertation was actually to ask if people get better with their upper limb capacity, what they're capable of doing with their paretic upper limb in the clinic. Do they then go home and use that paretic upper limb more? And so this was a secondary analysis from a dose response trial from Catherine's lab. We had 78 individuals with chronic stroke, and they went through an 8-week high intensity task specific training intervention for their upper limb. What I'm showing you on the y-axis is the use ratio. We had all of our participants wear bilateral accelerometers for 24 hours every week they were in the study. The use ratio is a metric that we've derived from the accelerometer data that's simply an expression of how often your paretic limb moves relative to your non-paretic limb. The dashed line across the top is a referent value, so very close to 1. So we tend to, in neurologically intact adults, we tend to use our 2 hands together for almost everything we do throughout the day. What I'm showing you, again, on the x-axis is time. Now, the black line represents individuals who did not have a clinically meaningful change in their in-clinic capacity. The red line are the people in the study, and it was actually fairly evenly split, people in the study who did have a clinically meaningful change in their in-clinic capacity. So they improved their capacity for movement in the study. But you'll see here that these lines go straight across, and the slope estimates are about as close to 0 as you can get, which means that even though they were getting better in the clinic, they did not go home and use their paretic upper limb more. And since this project, which came out in 2017, we now know that the same problem exists for walking as well. This was a study that had 48 individuals with stroke and then 57 individuals with Parkinson's disease. And these individuals were all going through a standard course of outpatient therapy. They were not being brought into the research lab. And they tested to see who was improving in their capacity and who's improving in their performance. The gray color represents everybody who had a significant increase in their in-clinic capacity. So you should note right away that everybody in the stroke cohort, all 48 people, had a significant improvement in their in-clinic capacity for walking. And 32 individuals with Parkinson's disease had a significant in-clinic improvement in their capacity.
So when you talk about significant, this is clinically significant?
Yes,
Okay.
yes.
And is that the 6-minute walk test or?
They use the 10-meter walk test for walking. Yeah, gait speed.
Can I ask for clarification?
Mhm.
So people have in-clinic improvement, but, and then on the last slide, you suggested that that did not predict a good use ratio upon discharge, but I would think it would be more clear to relate their use ratio in the clinic to their use ratio upon discharge. It's not so much the improvement, because we still don't know, they still may have had an asymmetry in the clinic, right? And it persisted, right? Is that what we're trying to convey there?
No, but it's interesting that you bring that up because we had a postdoc in the lab at the time, Mike Urban, who looked at the in-clinic metrics.
Mhm.
And actually the use ratio was above 1, suggesting that people were using in the clinic, they were using their paretic limb more than their non-paretic limb while they were in their hour therapy session.
And then not continuing. to do
Exactly.
So that, to me,
Exactly.
that's a little more, that's a little more direct.
Yeah. So Mike looked at those data. I'm
Yeah.
sure he has published this at this point.
Mhm.
But basically, we were able to get people to drive their use up in the clinic with their therapy, but
Right.
then when they went home, they were not using their paretic upper limb more.
Mhm.
And so we have the people here in gray who had a significant in-clinic improvement in their capacity. Oops. Is the green showing up? Yes, it is. And the green color are the individuals who had a significant increase in their performance, or had a significant increase in their daily steps at home. She noticed that there are no green people in the stroke cohort. So even though everybody improved their in-clinic capacity for walking, 0 people demonstrated a significant improvement in their daily steps at home over the course of a standard outpatient therapy run. And then we had 6 people, and they had 6 people in the Parkinson's cohort that demonstrated a significant increase in performance. This person down here actually did not have a significant increase in capacity, but did have a significant increase in performance. So they did observe that in 1 person in the sample. And so why does this matter? Why study this problem, or why should we be spending time on this? Well, the first is that there is an increasing demand and cost for rehabilitation. The demand is skyrocketing. So there's a lot of pressure for us to maximize our outcomes. And if people are not translating the improvements, or not reliably translating the improvements that they're making in the clinic to home, then there's an opportunity here to try and address this and figure out how we can help improve what you're doing when you're not with us. We also know that physical activity is low and it declines over time post-stroke and with adults with PD, and that this low physical activity contributes to further medical and functional decline. And so this is an important issue just in terms of overall health and longer-term function to address. And then lastly, we really lack scalable programs to help translate skills to home. And then also just promote physical activity in the home environment, which is a really critical part of self-management over time. And so I've tried to motivate the problem here a little bit, and that therapy works, people get better with rehab when they come into the clinic, but people are not reliably translating those improvements to home. And we really haven't spent much time thinking about how to help motivate people or address real-world performance. And so I'd like to spend a little bit of time talking about behavioral economics and introduce to you what that is and what I mean when I say that. And then we'll move into how we use behavioral economics in our work. So behavioral economics is a field that really exists at the intersection of psychology and economics. And it helps us understand how and why people make decisions. Behavioral economics also helps us understand how our decision-making can deviate from those that are expected to maximize our long-term outcomes. So why do we know that increasing our physical activity or eating a healthy diet, we know that that can help us be healthier, but yet our decision-making in the moment may not align with that longer-term goal of wanting to be healthy or live a healthier lifestyle. And behavioral economics then we call these decision errors, and these decision errors often occur in sort of a systematic way. And because they're systematic, we can use these decision errors to then help inform our intervention design and how we can motivate people to better align their decision-making with their long-term goals. So I'm going to focus on a few decision errors or decision biases that are most relevant to what I'm going to talk about today, but know that there are hundreds, if not thousands of these that I could spend the rest of my time talking about. But we know that from insights in behavioral economics that our decisions are impacted by loss aversion. So we will work harder to protect ourselves from a loss versus a gain of equal value. And so we can leverage this in our interventions by using loss framing versus gain framing. And I'm going to explain how we do that shortly. We also know that our decisions are impacted by peer perceptions. We care about what others think of us. We are more motivated to act or change our behavior if we know that our peers might know about it, or if our performance is going to be seen by somebody else. And so you can leverage this to help motivate individuals to act or change their behavior by using what we call social incentives. We also know that our decisions are impacted by a present bias. We prefer immediate gratification versus delayed or longer-term gratification. And we also are highly motivated by rewards and feedback. And so combining those two, we can help motivate people to act or change their behavior by providing regular feedback and rewards that's as immediate as possible to the behavior versus delayed down the road. We know that individuals are also more motivated to act around temporal landmarks. The most obvious example of this is actually New Year's resolutions. There's something about the turning over of a new year that people are just really motivated to like put into play a behavior change or something that they want to do over the next year. But even on a lesser scale, people can be a little more motivated to act or change their behavior at the start of a new week or a new month or at your birthday. And so you can leverage this by offering fresh starts. And so I'll again explain this in a minute about how we do that. And then lastly, we know our decisions are impacted by the intention behavior gap. So oftentimes we intend to make a choice that aligns with our long-term goals. I'm going to change my diet so that I'm, live a healthier lifestyle. But then the behavior that we actually display doesn't align with our intention. And there's a gap between the two of them. And so you can address this by offering a commitment device to help bridge this gap between what you intend to do and what you actually do. I will pause here. A commitment device is actually used in CIMT. It's called a behavioral contract. And so for those of you in upper limb research or familiar with the CIMT literature, part of engaging in this intervention is signing a commitment contract that says, I will, wear my mitt for 6 hours and I'll do all the exercises at home. And so that's, I think, a really nice example in the rehab world of how this has been used in prior studies.
Quick question.
Yeah.
I notice effort isn't on your list. Does that fall under the rubric of behavioral economics? I mean, we do things, we prefer things that are easier to do and shy away from things that are harder to do, right?
Yeah.
And the reason I raise that is that there's, we'll get to this later, maybe if we have time, but there's evidence in limb choice that people make choices on the basis of which limb is easier to use,
Yeah.
right? So I'm gonna be curious throughout about the intersection between some of the things we study and the way you might frame it.
Yeah.
So I'm curious, that doesn't come up on your list.
Yeah, that's a really good point. So we don't tend to talk about effort in behavioral economics world. We tend to talk more about motivation and how do we help motivate people to make decisions aligned with their longer term goals. Where they might intersect though, is that tasks that require more effort, or you might really not be motivated to do because it requires a lot of effort, how you would have to motivate that person to choose that task is where behavioral economics would come in, whether it's through rewards or how you frame a task, how the feedback that you provide and the frequency of which you provide it would be a way that it would intersect and that you would think you'd need more input to help someone to engage in a more higher effort task or something they're really demotivated potentially to participate in versus a task that you're kind of motivated at baseline to do and you may not need as much input. Yeah.
One thing to add to that is effort. It can often be framed as, whether this is strictly true depends heavily on how you quantify effort or define it, operationalize it, I guess would be a better term. But it's kind of a cost. And so it also kind of competes with the provision of reward as a way to motivate it because it's sort of, you're averse to it. It's kind of a loss.
Right.
Just adding that to them.
So it could fall under the broad rubric of sort of reward, cost benefit to doing a certain thing.
Yeah.
Oh.
Yeah, but I would say it intersects at the level of motivation and the type of ways that you would want to motivate someone to engage in that, high effort task. And yeah, rewards would be an option. I think that would probably be the most low hanging fruit for that.
I think it will also interact with the loss aversion, right? Like even if it is helpful, and even if it is effortful, if I foresee that doing that effort is going to kind of help me in the long run and prevent me from that loss, I might be more inclined to do it.
Yeah. Yeah, this is a really interesting thing to think about how they intersect. So thank you for bringing that up. I will say that there's a tremendous amount of literature of how other groups have leveraged these insights from behavioral economics to help increase daily steps or physical activity in a variety of clinical populations. But what I was really interested in is that no one had ever really tried this in adults, more rehab populations, people post-stroke, people with Parkinson's disease. And so I wanted to see, can we leverage these insights from behavioral economics to help motivate people to increase their steps at home? And so that brings us into the next part of our circuit where where we're gonna spend the rest of our time together. And how do we apply these insights from behavioral economics and different scalable technologies to help motivate people to increase their activity post-stroke or with Parkinson's disease? So the first project I'm going to share with you is what we call the Be Mobile Behavioral Economics Improve Mobility Pilot Clinical Trial. So again, this was just a pilot, so we'll keep that in mind. And the central question I was asking was, can we leverage behavioral economic principles to increase daily steps post-stroke? I want to pause and call out a few study features that I just want to put top of mind for you as I talk about this trial. The first is that this was a fully remote design. We didn't bring anybody into the clinic. In fact, I've been at Penn now for 5 years and I have not met any of my research participants in person. We don't bring anybody in. It's fully remote, which allows us then to reach people who live really anywhere. And I'll show that in our VA work. We also use different scalable technologies that enabled us to run this remotely. The first is that we use the electronic health record to identify potential participants in the Penn medicine system. We use a remote monitoring platform that I'm going to describe on the next slide that really automates a lot of features of the study that enables us again to run this remotely. And then we use wearable devices, Fitbits, which you're all, I'm sure, quite familiar with, to record daily steps. I'm going to call out the different behavioral economic principles that we used in this trial to help motivate individuals. And then lastly, there was not a therapist who delivered this intervention. And so this was really automated through the platform and did not require therapists to bring someone into the lab to give them a specific intervention. And so our remote monitoring platform that we use is called Way to Health. This is a research technology platform. It was developed in-house. It's housed at Penn, but anybody can use it from outside universities. And it's really quite a powerful platform that allows us to first collect informed consent. We can administer all of our study surveys to participants through the Way to Health platform, and then it automatically syncs your daily Fitbit step data to the platform. It comes into Way to Health. They calculate where your steps above or below your step goal for that day, and then we can send automated messages to each participant via text or email. And so this allows us to not have to, participants don't have to manually record their daily steps and share those with us. We don't have to bring people in for consent or survey administration. And so it really is a powerful platform that does a lot of the work for us. And again, if you're curious about it, I'm happy to entertain more questions. So let me tell you a little bit about the trial. Everybody went through a baseline period that was 2 weeks. We used data from week 2 of the baseline period to calculate everyone's baseline activity. So we took your daily steps from the second week. We did not use the first week to avoid any upward bias and just simply putting a Fitbit on in case that motivated people to walk a little bit more. We did not see a difference between the 2 weeks for those of you who are curious, but we just used week 2. And then individuals were randomized to either a control arm or a gamification with social incentive intervention. For the control arm, everybody selected a step goal, and this step goal was either a 33%, 40%, or 50% increase above your baseline. So it was individualized to your baseline step count. And then went through an 8-week, that's all they had. They had a step goal, and then they went through an 8-week recording period. For the gamification with social incentive arm, we had everybody, again, select a step goal, 33%, 40%, or 50% increase above your baseline. But we also asked individuals to sign a pre-commitment pledge. So this bridges that intention behavior gap. And all it said was that I will do my best to try and meet my step goal every day for the study. We asked individuals to choose a support partner. Now this support partner came up with what we called goals, but really it was just 3 ways that they were going to help encourage or support this person to help meet their step goal. Support partner was most often a spouse or a friend, but we did not restrict who you could select. And this is the social incentive piece. And so this support partner was going to be made aware of how you were performing in the game and in the study weekly, because we know that that can help motivate people to meet their goals. And during the 8-week intervention period, individuals participated in a game with loss framed points, and I'll unpack that on the next slide. We used both daily and weekly feedback. The daily feedback was the form of a text message where we just sent everybody a quick note to let them know if they met or did not meet the previous day's step goal. Because we know that more immediate feedback is better than delayed feedback. So every morning you woke up knowing if you met or did not meet the previous day's step goal. Most people already knew because they would track it on their Fitbit device, but we would send you a message. The weekly feedback summarized what level you achieved in the game over the last week, and that came via email. And the social incentive piece is that your support partner also received a weekly email telling them what level you achieved in the game in the last week, and then reminded them of the 3 goals that they identified for how they could encourage or support this person to meet their step goal. And then lastly, we leveraged the fresh start effect. So that's the temporal landmark piece by reloading everybody's points in the game at the start of every week. So I'm going to bring this gamification piece together a little bit more for you here and show you a figure of how we did this. So the gamification intervention is not an app. Individuals saw this picture, and the goal of the game was there had 5 levels. Everybody started at silver, so you could immediately go up or down in the game. The highest level in the goal was to reach and stay at the platinum level. And at the beginning of every week, participants received 70 points into a virtual account. That's 10 points for every day. Now, we leveraged loss framing, but on the days that you met your step goal, you retained your 10 points for that day. On the days that you did not meet your step goal, 10 points were deducted from your account. So this is different than gain framing, where you have to complete the task to then get the points. We gave you all your points up front for the week, and we only subtracted them on days that you did not meet your step goal. And then at the end of the week, you advanced a level if you had at least 40 points. So you needed to meet your step goal at least 4 out of 7 days of the week. And then you dropped a level if you did not have those 40 points. A quick example of some of the feedback of the daily,
So is that loss aversion? Is that the principle you're using here?
Yeah, so yeah, loss aversion and loss framing. Example of the daily feedback that we would send is a really quick text message saying you met your goal, good job, keep up the good work. We always encourage people, if you didn't meet your goal, we would say, you didn't meet your goal, but try and sneak in a few walks today, you can do it. All these messages were designed to be encouraging of it happens, try again today, or, things like that. So we tried to always make sure we ended on a positive note. And we never had anybody respond. And in a few other trials they did, their days you didn't meet your step goal messages were a little bit harsh, I thought. And so we were really mindful of these need to be encouraging even if you didn't meet your goal. So this was a pilot study. So our goal here was to identify, can we detect a clinically meaningful signal? We're not trying to draw conclusions about efficacy, but are we moving the target at all? And so I'm going to show you our 2 outcomes because you don't get too carried away with outcomes in the pilot study. We observed that the gamification arm had a significantly greater change in their daily steps from baseline relative to control. On the y-axis of this figure is mean daily steps. And then week is along the x-axis. The orange line is the gamification arm and the blue line is the control arm. And we observed an adjusted change in daily steps between the 2 arms of 981. And so if you were in the gamification arm, you on average increased your daily steps by just shy of 1,000 steps relative to the control arm. So this was really encouraging to see. And so we were moving our target and increasing daily steps. And the second outcome we were interested in was the proportion of days participants met their step goal and the difference between that. And we found that the gamification arm met their step goal significantly more versus the control arm. The y-axis in this figure is the proportion of days that people achieved their step goal. And we actually found that there was a 41 percentage point difference between the 2 arms. So the gamification with social incentive intervention appeared to really motivate individuals to help achieve their step goals relative to the control arm. Yeah.
So you said they had a self-selected increase in steps that they had to get, right?
Mm-hmm.
what was the distribution of that increase that they picked? Because if you think about it, like, if you just pick a lower value, especially in gamification, when your goal is to kind of, increase it, was there just a lot of people that only got like, that only want to increase by like, what, 25%?
33% was the lowest option.
So was that like the option that most people picked, or like, was it varied, or?
We had slightly, I would say we had very few people who picked the 50% increase. A few, probably a little bit higher rate of people picking the 33%, but there was a decent number of individuals who also picked the 40% increase.
Okay.
Mhm. Yeah,
How did you pick those three values?
that was
Were they
based off
different
prior
enough?
work.
Okay.
Yeah, that was based off prior work and doing this similar work in other clinical populations. Yeah.
Just curious, what was the baseline capacity of these participants? Were they severely affected? Well,
Yeah, so I can tell you the baseline steps were about 4,200 to 4,300 on average between the two groups. So that's time point zero here, and there's no difference between the two. We didn't bring people into the clinic to do a formal battery of how severely impaired you were. You did have to be able to walk outside of your home. You could use an assistive device, but you had to be able to walk outside of your home without physical assistance. So that was our kind of our key kind of screening criteria. And that was self-reported. So people are usually pretty good at identifying that, but it was self-reported.
I have two questions, I guess. And the first one is, I noticed that in both your step counts and your sort of days achieved, that although the gamification group is better, there is sort of a downward trend. So are you worried that if you go out long enough that your gains are just gonna disappear?
Yeah, this has come up before. I'm not worried about that yet. However, in other trials that have been efficacy studies and fully powered in different clinical populations, so not in stroke or PD, they have found that the follow-up period, there is a drop in the increase in steps, suggesting that when we turn the intervention off, those gains are not maintained at the same level. They stay above baseline. They kind of go like halfway between where you were in the intervention and baseline. So there's a retention issue, I think, in these types of interventions. Currently working on a grant to try and have a longer intervention period and have a follow-up period to investigate this a little further.
Right, but this is happening even within your intervention, not even before you get home.
Yeah, again, I'm not too worried about it yet because this is a really nice increase of about 2,000 steps. These are unadjusted, 2,000 steps. And so even if you're dropping off a little bit, you're still 1,000 steps above where you were at baseline. So I'm not too worried about that. But it is something to pay attention to.
And then my second question is, so you have like Parkinson's and right?
This is just stroke,
Oh, it's
but
just-
we are doing a trial right now on people with PD.
Because I was gonna ask about whether you knew that these people were actually sensitive to loss before you started to implement loss aversion type measures.
Yeah, this comes up a lot in our PD work. We did not, and I'll share the trial that was currently underway in the end, but I wouldn't say we have a way of directly looking at if you're sensitive to loss aversion before having people participate in this game, but in the data that we're seeing from the trial would suggest that we are seeing a significant increase in daily steps for people who are in the gamification intervention, but that would be an interesting thing to tease out in future work.
And you don't have any measure of the speed, right? Did you say?
No.
Yeah. It's kind of, I don't know how you would do it, but it's a little unfortunate because as I understand this thresholds like less than 0.44 meters per second, they're kind of homebound. I could imagine that as you get across a certain threshold, you might if you're restricted to the house or, I don't know, I'm just thinking about adding another variable, which is speed, to
Yeah.
whether people self-perpetuate and it's maintained.
So we didn't have a direct measure of speed, but what was interesting is that George Folk's group took daily steps, and I think they used 10-meter walk speed for one of their trials where they sort of gave you the step range of people who were at home, limited community, and they used steps. And so what we actually did was we stratified our randomization by baseline steps, and by those categories, you had to have 7,500 steps or fewer in your baseline. If you were taking more than 7,500 steps at baseline, you were excluded from the study, just of a ceiling effect, and this wasn't the right study for you. If you're taking 7,500 steps after your stroke a day, have at it, right? Like, keep going. Yeah, go for it. And so we did, it's not directly related to what you're asking, but we did sort of look at the literature, and the George Volk's group really gave me a big alley-oop, and that I could use baseline steps to sort of approximate those levels.
But I think that is a good point, because, Nicholas Regoffers work initially showed that there was sort of this threshold beyond which, if you reach that threshold number extremely, then people continue to improve. I don't know how they continue to improve, but you have to reach that threshold.
I do think if we go back to some of the data that I showed earlier, in the stroke cohort from Catherine Lang's group, everybody in the sample significantly improved their gait speed, their in-clinic measure capacity, but no one was walking more at home. And so the relationship between those two variables, I think, is hazier than we may be willing to admit. And so just to point that out.
This might be good.
Yeah, I have this question. So in the previous slide, you talked about those categories that can move between, like they started at silver and moved to gold.
Yeah.
Did you find, since the mean number of steps did decrease over the time, did they just like kind of start going to like the minimum they needed to stay in their category? Did you find those categories actually affected behavior?
We didn't directly look at that. If people were just sort of barely meeting their goal, if they were like soaring past it in the beginning and then barely meeting it, in the end, we didn't really look at that, but that's an interesting thing that we could go back and check out.
I was gonna say, it might be a good time to bring up something that has concerned some of us for a while, which is that one reason these capacity measures in clinic don't translate well to what people do at home is because they're so narrow, and you're really looking at, strength or synergy or, some very basic things which are sort of, one component really is being measured at a time. And capacity should be a multifactorial construct. That is, your capacity is different in different contexts.
Sure.
And under different loads and under different time pressures, there's so many factors that affect capacity. And our measures of capacity are not adequate to predict, or they're very poor predictors. And so one of the things a lot of us work on is how can we better measure capacity in a way that will translate better to the real world.
Yeah, that's an excellent point. There are certainly limitations in these capacity measures that may be partially to blame for why this relationship is poorly understood or not as strong as we want it to be. So that's really interesting. I think I see a chat here.
Could retention be increased if daily step goals?
Yeah, that's a great question, Erica. We did not intentionally.
The question.
Oh, you can't see it. I'm sorry. I
Yeah.
thought you could read it and I was just reading something you could already see. So Erica Middleton asked, could retention be increased if daily step goals are integrated with achieving functional goals? So for example, encouraging doing errands as part of gaining steps or walking when they otherwise would typically drive. We did not, very intentionally, we did not float that idea or make that part of this intervention because we wanted to be as pragmatic as possible and empower people to come up with their own ways for how they could increase their daily steps. In our ongoing work and in future grants, we are actually going to ask people this question though. How did you integrate? How did you increase your daily steps? Did you do it through functional activities or did you just take time every day to go out on a walk? I have a medical student working with me right now who looked at some other Fitbit metrics, including short activity bouts, long activity bouts in this sample. And we didn't really see a significant increase in long activity bouts, which would suggest that people in this sample were increasing their daily steps by incorporating it into other activities. A long increase in long bouts would mean that you were maybe going for that long walk, which is like every day at 3, I went out and I went for my walk until I met my goal, and that you were taking more than 300 steps at a time to be in a long activity bout. And so we can't say that for certain, but I think what we're seeing in those data would suggest that people were incorporating daily steps more throughout their day versus maybe going for like one long walk a day or something like that. All right, it's a great discussion. Please keep chiming in. I'm gonna move us forward real fast. There's a couple implications of this work. I'm gonna be mindful of our time. So we did observe here that leveraging insights from behavioral economics helped increase daily steps post-stroke. We're not gonna, again, not designed to draw causal relationships, but we were encouraged to see that it did help increase daily steps. Our wearable device, the wearable devices and the remote monitoring platform allowed for fully remote intervention delivery in each person's home environment. But we do acknowledge, and something I'm currently working on is evaluating longer term retention, what behavioral economic principles are necessary versus nice, and overall impacts on healthcare utilization. So that's some of our future goals with this work. But I wanted to touch on some of our work on the VA side and how we're applying these methods in veteran populations. And so we've been on this journey of learning about digital technologies and physical activity among veterans with both stroke or Parkinson's disease. And we have a particular focus on rural populations. And the reason why I'm really interested in rural populations is that because our traditional paradigm is that we bring people into the clinic, which means that we only recruit people who live within a certain mile radius of our clinics. They can come in. And for most of us, we work in urban areas. So we end up only recruiting or enrolling individuals who live in a fairly urban area, who have better access to different types of medical care. But when we remove that requirement, we can reach out a lot further and potentially enroll people who live in more rural areas. And I thought that a nice first step would be to just see if we could reach veterans who are rurally residing, who don't live near the Philadelphia VA Medical Center. Will they wear a Fitbit device? What do their daily activity habits look like? Because we really don't know much about these populations, largely because they're excluded from a lot of our studies. And so I ran a pilot study on the VA side where we had 40 veterans. They were all rurally residing. The VA assigns all veterans in rural urban code. And so everybody is geocoded within the VA electronic health record of if they're urban, rural, or highly rural. So it's very easy to identify who is living in a rural area. We had 20 people with stroke and 20 people with PD. And the way that we did this is I mailed a letter to veterans who lived in VISN 4, who had a stroke or PD ICD-10 code. The VA is organized around VISNs. That's called Veteran Integrated Service Network. The Philadelphia region involves 5 different states, so all of Pennsylvania, some of New Jersey, Delaware, little bit of New York, little bit of Ohio, a little bit of West Virginia. And so that is the Veterans Integrated Service Network 4. So we mailed, if you lived anywhere in the VISN with a rural designation, we invited you to participate. We obtained consent through the phone, and then we asked everyone to create a Way to Health account, the remote platform, and complete their surveys online. So again, they didn't have to come in to do those things. And then we mailed everyone a Fitbit, was set up instructions for how to connect this device to the Way to Health platform. And if you needed help, we just provided it over the phone, which is also what we did in the prior stroke trial, even if people were living closer to us. And then all we did is I asked people to wear their Fitbit for 30 days and share their step data via Way to Health. Again, because we just don't really know much about how these individuals move or how active they may or may not be in their daily lives. So it's just an observational study. And then they finished the study at 30 days, they got to keep their Fitbit and were compensated.
Can I just ask one
Yeah.
thing? So you didn't actually see many of these patients at all?
None of them.
Not even their face or anything?
Mm-mm.
And do you know that they actually wore it or their partner could have worn it?
That-
Because we find that some of the patients lie, and we need to keep a track of, we've caught them out a few times.
That's interesting.
Yeah.
Yeah.
So I'm just trying to get a feel for it. So really, it's really interesting that you don't actually have to meet them. I think that opens the scope in rural. Okay. But you had no way of determining if it was them wearing it or.
No, we did not directly ask, are you the one wearing your device? Yeah.
Okay.
That's interesting. I guess I have not observed that in any of our prior work, so it's not something that's top of mind. So you raising that point is very interesting. That had people wear it on very weird parts of their body or wear
I
like
see.
chains where they're wearing, you know, it's like, no, please wear it on your wrist or wear it on your hip or whatever, but never
Okay.
switch out with a partner or something.
This is great, thanks.
Yeah. And just real briefly, again, this was more of a feasibility observational study. We wanted to see, can we enroll people? Will they finish the study? Will they wear their device? And we had an 11% response rate to our mailed letter invitation for veterans with PD and a 6% response rate to veterans who had had a stroke. I will point out, this was during the pandemic. I think we actually started pre-vaccine. And it included some winter months. And so we had to work a little harder to get people to think about a physical activity study in the winter during a pandemic. But we did have a pretty good completion rate. So we defined completion of after we obtained consent. Did you then create a Way to Health account, wear your device for the 30 days and finish the study? The PD cohort, actually what we learned some really fascinating findings as to when people fell out of the study, and almost everybody dropped out after consent before creating the Way to Health account. And so that was a really key finding, that in a trial we're now running where we realized we need to give people more support or better instructions to get them to the Way to Health platform to create their account. Because once they did that, they wore the device, they did the surveys, they completed the study. So that was a really helpful finding for our future work and interventions. Yeah.
The instructions on wearing the device, did you want them to just wear it for like most waking hours, or did you want them to wear it 24/7?
We asked them to wear it for their waking hours. Some people had their own approach when they sleep. Most people would take it off and charge it. They had their little, we heard this so many times. I have my charger by the bed. I sit down to go to bed. I put my device on the charger and then I put it on when I wake up. Yeah.
And in this study, were all these patients able to talk?
Yes.
Was that inclusion criteria?
Yes, you had to be able to walk. I think we did the same thing, or walk outside of your home. You could have a device, but without physical assistance. And if you had had a fall in the last 6 months, you were excluded. The VA gets very cranked about falls, rightfully so. So we couldn't even do 3 months. It had to be a 6-month fall window. And then in terms of device adherence, we have observed this for upper limb work and other studies as well. People wear their devices. Adherence is not an issue in these cohorts. And so 97% of the PD cohort wore their device for all 30 days. And 95% of the stroke cohort wore their device for all 30 days. What did we learn? This is the finding that I'm most proud of, even though this figure is a little bit of an eyesore, and I apologize for that. Is that participants lived an average of 252 miles from Philadelphia, our study location. This is VISN 4, this thick blue line encompasses the VISN that I mentioned, and every blue dot is a veteran who enrolled in our study. So you can see they're pretty spread out across the VISN, which was really encouraging to see. My map making skills improved between this one and the next one I'm going to show you. So a couple of other interesting findings. I apologize, this is kind of small, but we did observe that daily steps were low, but considerably variable between participants. So the veterans with stroke are on your left-hand side and veterans with PD on your right-hand side. We found a median step value of just over 4,500 in veterans with stroke and around 2,800 in veterans with PD. So our veterans with PD who live in rural areas had significantly low levels of daily physical activity. Just to get ahead of any questions, because I know it might be coming, these individuals with stroke who are floating up here around 15,000 steps had returned to work, and they conveniently worked in maintenance in a hospital. And so they were walking all day long. And so that attributed to a lot of bringing up that step count.
Sorry, this is baseline?
This is over the 30-day period.
Oh, okay.
Yeah. And then from all of our surveys and other things, we were interested to see if we could identify maybe some clinical or patient factors that were most associated with your daily step count. And we actually found that age was the only significant predictor of daily steps in both veterans with stroke or veterans with PD. It was really pronounced in the stroke cohort, where for every 1 year increase in your age, you're taking about 375 fewer steps per day. And then just around 180 for veterans with PD. So kind of creates a motivation to want to target older veterans who have stroke or PD, who may really be struggling with ways to increase their daily steps.
And Kim, you didn't have any measures of stroke severity or initial PD severity. So if you did, that would clearly have been, I would think, would have been a predictor as well.
Yeah, we did have, so we had disease duration, which doesn't necessarily mean anything about your like severity of your disease or symptoms.
But like you could have used film or something.
No, we didn't
or
have that.
something
Yeah.
like that,
Yeah.
and probably would have been a predictor as well.
Yeah, that would have been interesting to look at. We are in an ongoing trial we have more measures of like motor, non-motor symptom severity and PD, the PDQ-8. We have included a lot more of those. And so the last thing that I will talk about is how we use these findings from simple observational study to design a gamification intervention to increase daily steps for veterans with PD. This is an ongoing trial, so I don't have the final results for you. It will end in June, so stay tuned. Hopefully, best laid plans, maybe by the end of the year, beginning of 2025, the results will be out. But we had 76 veterans. This is a single arm clinical trial. So it's funded by the DoD, and they, for whatever reason, restricted randomization to a control condition. So everybody is going through the intervention. And we're using very similar methods to what I've already shown in some of our prior work, where we mail an invitation and we obtain oral consent over the phone. All the veterans create a Way to Health account and complete study surveys. There's a 14-day baseline period, which is what we did in the B Mobile trial, a 6-week gamification intervention, and then a 4-week follow-up. This intervention, though, we do not have a support partner. So this is just the gamification component. We did not include the support partner just for a couple of logistical reasons. And we're also trying to tease out like, well, maybe the game might be enough and sort of collecting pilot data on just that for a grant we just submitted a few months ago. That's an efficacy trial. One thing, yeah.
Do you find that the older members of your subject population are maybe occasionally frustrated by the technological gaming component instead of encouraged by it, or?
We rarely hear frustrations. When we hear frustrations, it is usually always around the Fitbit device setup. But we've also found that a lot of people just have like a grandchild. They don't usually want their spouse to help them. And then for whatever reason, veterans are like, no, I don't want my spouse. I can do this, or I'll have my grandchild do it, or an adult child. It's really, we didn't hear that in our like non-veteran work. And so we hear more frustrations around the device setup. The game, people find pretty motivating. They are invested. My email is actually attached to the weekly reports that people get of their performance in the game. So I have gotten multiple emails where it'd be like, my step count was wrong on Tuesday, but it was this, or like, I thought I had 40 points, but the email said this. And so we have to go into the platform. Like they are very engaged in it, which is really cool to see. That's not true for everyone, I'm sure. But the complaints we hear are really around device setup.
This is sort of a minor point, but I'm curious because the purpose here of the study is to sort of draw conclusions based on being in a gamified environment. Did you restrict, so the Fitbit app itself has a lot of gamification built into it. Did you restrict that they had to use the study game and they couldn't use the Fitbit app?
The Fitbit device that we're using in the app, the most it really does is it might just like buzz you randomly. We still can't figure out when they do this to like take a stand or try and walk a little more, but we don't program our step count into the device, but we use a simple tracker instead of some of the smartwatches and things. And the Fitbit, at the time we started this trial, Fitbit wasn't doing as much with that as they might be exploring a little bit now. And so we haven't found it to really be too big of an issue. But we did not restrict it to answer your question.
Yeah, so your control group, because I had a Fitbit, it's the app like has a little thing and you get little trophies for like hitting your step goals and stuff. And so
if you don't program your step goal in,
yeah,
then I don't know if it gives you all of that.
sure, but it hinges on them having not done that.
Yeah, so we do not have them enter their study step goal into their Fitbit. I'm actually would like to start doing that more though, because I want to move away from texting people every day. As I don't know about you guys, but I get a lot of texts from, like, it's like election season and, doctor's appointments from, all these news, just like, oh, please stop texting me. And so I'm actually kind of interested in trying to maybe see if we can tap into some of the built-in features, to remove the need to text every day, but we haven't done it yet. Yeah.
Sorry, in neither of the studies, just from my understanding, it doesn't involve a competition component with a social incentive, right? It's just they can see on their own scores. There's not like a scoreboard or anything like that. Okay,
Yeah, so we actually call that, in social incentives, there are different types. I'm glad that you asked this. In other studies, largely with veterans and non-veterans who are overweight or obese, there's competition or collaborative social incentive where your performance is made available. You're either on a team of other people in the study, so you're collaborating and someone's randomly selected and you're sort of representing the team that week, and then competition where you're sort of competing with other people in the group.
neither of these studies.
Correct. So real briefly, you should recognize a few of these images from our prior work in terms of the technologies of this trial. Where we use gamification. Game looks exactly like it did in Be Mobile. We use the Way to Health platform and the Fitbit device everybody wears on their hip. But one cool thing about this trial is that we're using the Parkinson's kinetograph watch, PKG watch. I'm not sure if any of you are familiar with this. Again, it's a wristwatch, but it measures symptoms of PD, bradykinesia, tremor, and we ask people to wear it for a 24-hour period at the baseline, at the start of the intervention, end of intervention, and end of follow-up. And so we can see if there were changes at all in your Parkinson's symptoms that may or may not be associated with an increase or no change in daily steps. So that I don't have those data, but that is a cool device that we've been working with for these trials to help dig in a little bit deeper on symptoms of PD and how that might relate to a change in daily steps.
And this is available in the market, like.
Think of it as like the same concept as Actigraph. It's like a research grade device. So, and they actually, it has an API. Way to Health can interface with devices that have an API. But PKG, they prefer us to send them the device and they like upload the data and generate the reports. So we have to do that. Now, it's one less thing we have to process, but it is kind of a racket to like get the device to them. Yeah, they're very protective of their algorithm, which is similar to Actigraph, only Actigraph's getting a little bit better. So these research grade devices still are a little bit of a black hole in terms of like downloading the data and processing it.
And then I guess they couldn't change their medication regimen over the time of the study, is that right, for the PD?
We would ask if they did.
I see.
We asked them if they've changed in their medication.
Did you have any deep brain stimulation patients or?
No, we did not. This sample is actually a little bit mild for in terms of PD. I don't think we have many people who would be at the DBS point yet. At least I don't think, on average, I think our sample is about 5 years in terms of disease duration. And I also think the VA asked us to not to exclude people with DBS because they're pretty protective and cautious.
When you say disease duration for PD, is that time from diagnosis?
Time from diagnosis. We do ask them to tell us the date where they first started to experience symptoms of PD. And for some people, that's a 10-year gap between when they first started to experience symptoms. So when it comes to the actual analysis, I don't know if we've decided if we're going to do time from diagnosis or time from first symptoms, because there's a big gap for a lot of these individuals.
Well, I mean, it's hard for some patients because they don't know exactly what is Parkinson's or not.
Yeah, exactly. So yeah, that's kind of hard too. And some people didn't know, and so they, we had to call them because they left it blank. So we call them and we had to kind of talk through it. We'd go back to their medical chart and see if we could get a sense. All right, so my map making skills improved from the prior study to this one. There's still room for growth. But I'm very proud of this map, so take it easy if you notice a lot of flaws. But everybody is through the baseline period. So these are all 76 of our participants. We have a few people still in the intervention phase in the follow-up period. But we had rural and urban veterans from 5 states enroll in this study. Every little blue triangle is a veteran. We did not restrict it to just rurally residing veterans for this project, but we have 34% of our sample was rurally residing. And so we're really proud of that, that we were able to reach about a third of our sample who typically have never been in a research project or approached about research. And just briefly, what we observed in our baseline data is our baseline daily steps are about 3,600 across all 76 people. So pretty low levels of daily steps in the cohort. But you can see there's obviously considerable variability when you look at the individual data on top of this. So the implications from our work in VA and both stroke and PD, we, again, the remote technologies afford opportunities to reach people hundreds of miles away, which we're particularly excited about. It does come with some trade-offs of what information you can get from people, but we've enjoyed reaching people that typically are not included in our trials or our studies. The rurally residing veterans experience low levels of physical activity, very similar to their urban counterparts. And again, in our future work, we're trying to optimize intervention components, length of the intervention, and long-term retention of gains. And so I want to throw out just a few discussion points for us, and then I'm happy to stick around and chat for as long as anybody would like. But some concluding thoughts are things that I think about a lot is just thinking about the rehabilitation landscape. So there's a much higher demand for services and really not enough therapists to meet these needs. We're feeling this crunch in our health system where we just have wait times to get into CPT or OT are increasing because we just don't have enough therapists to meet the demand for all the patients coming in for rehab. And so I think that can help support thinking about interventions or ways to motivate people in home to do more things and be more active as we kind of feel this pinch in clinical services. I think a lot about scalability, and I hope my work today kind of got you thinking about it too. I mentioned that our current paradigms require therapist involvement or in-clinic visits, and those things can limit scalability. And also therapists are costly and a time-limited resource. So thinking about ways that we can reach people where they live in their home environments without needing a costly resource like a therapist to deliver an intervention. And then I'll leave you with it. I hope that you're thinking a little bit about how behavioral science offers a lens for how to motivate individuals to increase their activity at home and outside of the clinic. So thanks for the opportunity to share some work with you today, and I'm happy to keep chatting about this for as long as you'd like.
So it seems like a lot of most of the intervention was kind of like, let's just do as much as we can, throw everything kind of against the wall in terms of these behavioral economics principles. Do you have an idea, or has there been previous research on like which one specifically might be moving the needle more or less in either healthy or like these disease populations where the principles may or may not be the same?
Yeah, we think about that in terms of what's necessary versus nice. A lot of the principles I talked about are sort of rolled into the game, like the fresh start effect, the loss framing, those are all within the gamification intervention. Gamification, we know from prior work, is most effective when it's paired with a social incentive. Although I think the PD trial that's going to conclude in June where we didn't have a social incentive, it'll be interesting to see how much gamification maybe resulted in a step increase for veterans. So I don't think anybody's directly testing in terms of like a 3-arm trial and here's a few pieces here and a few pieces there, but sort of slowly thinking about this as we work on other projects.
I think a really sort of provocative conclusion one could reach from your study is that the way we currently provide inpatient and even outpatient rehab is focusing on some of the wrong things. That we're really focusing on improving strength, improving speed, improving these low-level motor capacities.
Impairments.
And we're ignoring the whole person, and we're ignoring all these other kind of factors that you highlighted so nicely in your work. And so I was wondering just to hear your thoughts about, in addition to gamifying and helping people to continue to keep gains once they go home, do you think this offers any insights for how we can treat people better in rehab?
Yeah, I think it does. And I think about the ProWalks trial that Dr. Reisman's group just finished up. I think the preprint is up. Thompson's the first author, where they looked at pairing an in-clinic PT intervention with different behavioral components to help the translation to home. And it was a 3-arm trial, and they actually found, not surprising, that when you paired your in-clinic intervention with, I think they did motivational interviewing, goal setting, for step target at home, it resulted in a greater increase in daily steps than when you just gave them a really good in-clinic
And the
intervention.
same was true of the constraint induced, the transfer pack,
But I
like,
think-
you know,
I'm gonna kind of
Yeah,
push back
yeah,
a little bit. But I think that inpatient, whatever, in clinic, high intensity training was necessary to give them that boost that they're able to walk. If you don't have capacity to walk, you're not gonna walk. So the question is,
well, right,
Okay.
not that it's not important, but was it sufficient?
It's not sufficient.
Yeah.
but it is necessary. Because
Mhm.
without that, you don't have the capacity to move your arm, or you don't have the capacity to walk. And then you're not gonna be able to, then the transfer doesn't even,
Well, to be fair, we don't know what the baseline status of a lot of these people were. Like, we don't know that they went from no capacity to some capacity. We just know there was a change in capacity.
The magnitude of the
Yeah.
change, yeah.
We don't know where they started.
And this may get to the threshold argument you were, if
there is,
if you can walk to begin with, then this.
Then this,
This
and I
treatment,
think-
and if not, then that treatment, that's the
Yeah.
kind of thing I think we need to, as we talk about precision
Oh, yes.
rehabilitation a lot,
Yeah.
to sort of tailoring the package of treatments to an individual person.
You know what, Amanda, I'm thinking of a paper by Maggie French now that was probably like 2016. It was a long time ago, where they
French,
actually found, Maggie French, that, they gave like a high, there at the time, whatever flavor of high intensity gait training it was, so it's not I think what's currently done, but a flavor of that. They found that for people who experienced the greatest increase in daily steps at home had the lowest capacity to begin with. So they had the slowest 10-meter gait speed. And so they did observe, and it was a small kind of pilot study, secondary analysis.
Everybody at the same step level at the start of the study?
No, nobody ever really is.
Yeah,
at the
because
same
that's like,
step
you have a
level.
question
You're
there,
never gonna have-
dynamic range. Like,
Right.
they went from taking 5 steps a day to taking 100 steps a day versus somebody who was already taking 80 steps a day, went to 100.
So I think the best data that we have to that point, is to your point about capacity, which is in clinic, is that the people who had lower capacity in the clinic in terms of gait speed or a 6-minute walk, I don't remember which test they used,
Mhm.
that saw the greatest change in daily steps, but that wasn't looking at adjusting for any sort of baseline performance metric.
Yeah,
So,
yeah.
yeah.
All to say, it's thorny.
Yeah, like most things, yeah.
Yeah, I would also maybe question some of these conclusion thoughts that you've had about, the use of these kinds of interventions, because I do think that, for some people at least, if, I definitely understand that if you're in a rural area, you may not have good access to care. But I do worry that in that case, you might be trying to give them like a game to play where they don't actually, or they could put themselves in sort of dangerous situations because they're trying to do more than they actually are able to.
Yeah, that's a very fair critique or point, and that's often why we try and individualize your step goal to your baseline level to make sure that we're not over challenging you or asking you to go from 2,000 steps to 10,000 steps. We have not, I'm gonna knock on wood, but across all these trials that I shared with you today and a couple others that I didn't talk about, we really haven't not had any study-related falls. We've had a few adverse events where somebody slipped on the ice in the winter, so we didn't have to, but like they were walking from their front door to their car, kind of to go somewhere. And so was that study related or just life related? But we haven't observed a significant increase in any sort of adverse events, which would suggest that we're not, yeah, I don't knock on wood.
Yeah.
Tomorrow I'm gonna email you and be like, guess what? We had 3 people who had a fracture yesterday or something. My collaborators would kill me for probably saying that, but that, I think that's a good signal that we're not putting people in too dangerous of situations where they're potentially harming themselves or falling or anything like that. But we think about that a lot. And a second point I'll share is I just found out this week my Career Development Award is recommended for funding, and part of my career. Oh, that's the feather in my cap, but the one of my aims is to tease out, and this is in veterans with stroke. Like, do you want to do gamification, or would you rather just maybe have a support partner, or try to get at these intervention components that you asked about earlier? Like, what, just a qualitative study to ask, like, what's motivating to you? What would help you to dig in a little bit deeper? Because we think gamification is effective, but maybe we'll learn that, like, people are just doing it because we're asking them to do it and they really don't love it that much. So we're actively working on trying to tease this out. Yeah.
First of all, I want to apologize for being late. I was actually delivering my remote physical activity.
Perfect.
But I wanted to make, well, first of all, I'm really interested in hearing more because I missed the beginning of your talk about your gamification intervention. But one of the conclusions that I think potentially comes from this work is that, you know, when we, oftentimes we think that we'll do something in the clinic that is impairment level or capacity focused, and that's going to automatically lead to changes in, you know, people's functioning in the environment and ecologically valid context. And I think that we have to look at, you know, our outcomes that are related to impairment, we're most likely to see with those types of interventions with focus on building capacity, but anything that's related to functioning is going to be better served by interventions that are good at reaching somebody in their environment and helping them when they're doing the activity. And so I think that this sort of suggests that these remote mobile interventions are going to be better at that because they're meeting the patient where they are. And that, like, if you think about the variability in step count in this room, probably among people with similar capacities is probably wide. But if you target, you know, steps out in the community, then you'll have more of an effect in changing steps out in the community. But I think that it's important to think about with rehab, we probably need to pair those strategies if we really want to impact day-to-day function.
Yeah, I agree. I think the ProWalks trial is really a really nice example of how you compare those things. I have a grant that I submitted to try and pair a behavioral intervention with in clinic or with outpatient PT to try and help the translation. So so we're working in that space, but I agree. I think it makes people uncomfortable. So, you know, cause like you have to give up a lot of control when you're delivering an intervention in a home environment, because everyone's environment is so different. And so what you can actively control or measure or monitor looks a lot different, and people get really uncomfortable with that. But I think if you want to change performance, then you need to have an intervention at a performance level. You need to meet people at that, you know, in their home environment and try and help motivate them there. Versus bringing them into an artificial standardized clinical environment and then hope they translate that when they go home. So thank you for that point.
Terrific talk. Thanks very much. I was just going to circle back to this, the platinum and the blue, and so this gamification and the loss component, because I hadn't thought about that really before, and that seems powerful. So I'm wondering, like, practically, you know, when you're running this clinical trial and you have the people who are so motivated and then the people who are kind of on the edge, you can almost see they're about to drop out. They don't attend some of their things, they're missing. So when you give them this negative feedback, is there an opportunity for them to reset, or could they get into a loop where they're just like, what's the point? I'm so far down towards this blue thing now. So what can you recommend for the rest of us to try and build that into our, you know, trials?
Yeah, we've done this in a couple of trials, and one ongoing trial in the VA where we actually will reset people. If you're sort of stuck in blue for, I think it's 4 weeks, and you're not moving and you're stuck in this low level and maybe getting into this cycle, we offer a fresh start where we'll bump you back to silver, and you sort of get a start anew and reset and try. I don't know if that's effective or not because that trial's ongoing, but But I do think there's an opportunity there to maybe think about how could we offer a bit of a fresh start to maybe break the cycle of just sort of in a negative loop. But that's I think important for rehab populations, because sometimes you just, it can happen. And when I think about how to motivate people in that scenario.
This is anecdotal, but have you used Duolingo ever?
I have.
That, the reason I raise it is it contains all of the elements that you talk about, and it's extremely effective. I don't know if any of you have done Duolingo at all, but it has, I don't want to take up all the time, but one of the things that's really important is the social contract, where you can have a partner and you see how well, and embedded in that is competition. So you see how well they're doing and you're doing, and you're working to a common goal, but if you're not pulling up your end of the stick, they, et cetera. So I do think that these things are quite powerful, and so I applaud. I think it's really good work.
Thank you. And I'm gonna start using the Duolingo example as, I think a lot of people use that app, so I should start using that as more of an example so thank you.
So I want to circle back on the point that Aaron made about, where they are kind of converging. And you said that you don't have long-term data, like in terms of, but based on your previous work in, like you said, similar games and social support has been used in other populations. In those studies, after the intervention stopped, what does the retention look like? Because the reason I'm asking you is twofold. One is, like, if you think about strength training, I do 6 weeks of strength training and my strength improves. And 4 weeks later, if I don't continue strength training, that's going to reduce. I have a friend who went to noon, and every week we got like, sign up for noon, sign up for noon, sign up for noon. And for 6 or 4 months, he was on noon, and then he stopped noon. And 3 months down the line, he's back to square one. So the question is, when it comes to longevity of these interventions, are we really putting too much expectation that they're going to kind of lead to this behavioral change that's going to be long-term? Or what are your thoughts on that? What does the data say? I don't know that.
Yeah, so we don't have data in our stroke or PD cohorts. We'll have the 4-week follow-up, but it's not that long of a follow-up period. In other trials, there's one that we did in veterans who are obese or overweight, where there was a 12-week follow-up period. And like I said to Aaron earlier, that there was a drop in daily steps. So they were still taking more steps than their baseline, but not nearly as much as interventions. You kind of drop to the halfway point. And we've seen this now in several trials, ones that I've been a part of or haven't been a part of. A trial just came out in Circulation. It was a year-long gamification with social support intervention, thousands of patients at risk for cardiovascular disease. I think they had about 10 or 12 people who had had a stroke. And they had better retention in their follow-up period. It didn't stay the same as the intervention period, but it didn't drop as much as other trials, suggesting that maybe that longer intervention period might have something to do with it. I kind of think we need to phase it a little bit. I don't know. I think this is like a whole line of inquiry you could build your whole career on, is just the follow-up period, or sort of what happens when you turn the intervention off. Because I do think there's a lot of evidence that shows that these skills are not retained reliably for most populations, even though you stay above your baseline. So it's not like you totally collapse and go back, but you're not saying your intervention level.
So I think just to build on that, I think you can draw a lot of insight from classic behavioral economics and psychology literature. Like the whole idea here is that you're sort of leveraging, you could attribute it to dopamine, but there's probably a lot of neurotransmitters involved and cortical areas and subcortical areas involved. But the point is that, I think we've known for a long time that when you take someone out of a reinforcement training system, you see extinction. And so these things kind of, my understanding of the whole bedrock or the foundation, theoretical foundation for them is that they're not designed to induce retention. You need to keep the stimulus.
Yeah.
You need to keep the reward stimulus in order to keep the mapping.
Right, and I was gonna suggest, and I think that's a really good point, and, you know, one of the things that I think, again, with my anecdotal Duolingo thing, the reason I've been doing it for 2 years is because there's a streak society, and there's a streak, you know, when you get recognized for 365, you know, days of doing it, and you get your new badge if you have over such and such. So you're rewarded for the longevity as well as the initial intervention.
Yeah,
And so that is something that could be built into many of these apps as well.
yeah. Yeah, I think that this, again, is like I'm really interested in this. I think that the early career grants are not long enough to give like the long follow-up period. So they have to go to like the R01 PCORI approach. But I think that, and Amanda, as you were speaking to, that this like eventually this should click into a habit. Right, eventually you would want it to click into it, but we don't know, but eventually the goal would be that this clicks into some type of habit where maybe you.
But that doesn't happen. I mean, that's the whole point. is
Yeah.
If you can start to space out when you provide the reinforcement signal, but you have to keep the mapping in order to keep the.
But they
trigger.
might map it to something else spontaneously, like a feeling of being, you know, feeling healthier or something, so it's
Sure,
not.
but if
no-
that was true, then you would see spontaneous adoption and.
No, but I think
behavior
it,
that we don't see.
well,
That's-
a
yeah,
lifestyle
that's an
change,
ideal.
yeah, yes, so, yeah.
Yeah,
And some of the work in, oh, sorry, well, just one comment, Wendy Wood, she's not in rehab, she's truly just like a habit automaticity, or not in rehab, and, you know, talks about how, I would just push back a little bit on that, people do develop habits, and you don't eventually need the same stimulus or the same amount of stimulus to trigger the habit, you just sort of like, that it can change, or that you don't, the level of what you need. So I guess I just think about some of her work in terms of like building, I think she's done some work in diet, and things like
That's the
that.
definition of addiction, right? Is that the stimulus triggers the behavior regardless of its. Even when it's like regardless of it.
So if you become addicted to running or to exercise, and it becomes.
You know, we use addiction to be sort of have a negative connotation, but that's kind of what the behavior is. But even in that case, my point is you still need the trigger stimulus to elicit the behavior. You do, I mean, just this is sort of classic conditioning behavior. You do need to provide the reward stimulus at some interval. Like you said, it doesn't need to be as frequent as when the initial training is happening, but you can't just take it away and expect that the behavior is going to continue forever. That's just not how.
I agree with that. So that's what I was getting at. So thank you. That's a perfect way to summarize it. But I also wonder, you know, it would be interesting to test that in this context here, like
Sure.
how long does it take to get to that? Like, I don't
Yeah.
need this
What
as
is the
often,
extension
or,
time like?
yeah.
Yeah,
mm,
absolutely.
On what Erica said, like embedding that into a functional activity.
Mhm.
If I have to go to the grocery store, let me walk. So that might be another way to kind of,
Pairing
I don't-
behavior.
I don't know this word.
Yeah.
This area, but.
Habit changing.
Yeah.
Is there any literature ideas about how you would maybe, transfer a trigger from one thing to another? Like, Dylan was saying, like, some people might just spontaneously, remap it to, like, just like feeling good, it won't be healthy, right? But like, that probably won't happen to a lot of people, but maybe it could be facilitated, like, in a way that could be, that might be interesting.
Yeah, that's really interesting. I think it's getting a little outside the scope of what I'd be comfortable responding to, but that's a very interesting point. So thank you for bringing that up.
Sorry, just curious, did they get to keep the benefits?
Yes. Yep.
So in that case, you know, we can always go back and ask, did you continue to wear it? Did you continue to keep up the steps? And, you know, that would be.
We did ask, and in the V-Mobile trial, so there wasn't a follow-up period. What I didn't share about the V-Mobile trial was that it was originally funded to be done in a slightly different in inpatient rehab, and we were set to launch in April of 2020.
Yeah.
So we had to pause. Jokes on us, like all of you, thought maybe, okay, a couple months, we'll hold, and then it became apparent we can't do this in inpatient rehab. So we had to design a completely different study in the 18-month sort of funding period, and it became the V-Mobile study. And so we just didn't have the time and to see if they kept wearing it, but we did ask them, like, do you plan to wear your Fitbit? Do you know, did you enjoy wearing it? And we captured that, and people had pretty much strongly agreed that they plan to keep wearing it. And people love the sleep data from Fitbit, just as an aside. We don't do anything with it, but people were very invested in their sleep scores and sleep data.
Yeah.
They were really, the calls we got, people wanting us to explain the sleep data, and we're like, we can't, we don't,
Yeah.
have fun, you know, kind
And
of
if
thing.
that, if it correlated with the steps, you know, if the more active you were, you had better sleep or.
Yeah, I have a couple papers in this in a larger study that wasn't stroke or PD, and we couldn't ever really pin down those relationships, but I don't think that it's a good device for sleep data for research, but anyway, did you have a?
Oh, I was just gonna say, as someone in grad school, I was in a study that looked at, gave us Fitbits, looked at improving our activity levels, and I track my active minutes per week in steps ever since. To be honest, I don't know if I've maintained the same level as, when I was in the study, and I'm obviously not the population that you're talking about. but
Yeah,
just anecdotal, that's maybe-
people are fairly interested in, and I think what we do is, we don't set out to do this, but I think for a lot of people is that we help boost their confidence that they could use a device to track their health, and that's what they needed, and they kept doing it. So we didn't set out to do it, but it was a nice kind of byproduct. Thank you,
so
everyone. Thank you so much.